lecture. In this lecture, I am going to talk about thyroid storm or thyroid crisis, the clinical presentation, the pathophysiological changes, and the management of thyroid crisis or thyroid storm. So it's an acute form of hyperthyroidism which results from unrecognized or untreated hyperthyroidism. So it's a severe form of hyperthyroidism. It's a medical emergency. It's a life-threatening condition which requires hospital admission with a mortality rate of 10% despite early recognition and treatment. Some of the common triggers for thyrotoxic crisis are infection, trauma, surgery, any stressful condition, diabetic ketoacidosis, pregnancy, or exposure to iodine-containing drugs such as amiodarone. Now let's discuss the pathophysiological changes in thyrotoxic crisis. So the figure here shows the pathophysiological changes which is characterized by elevated T3 and T4 levels and excessive thyroid action. Because of excessive thyroid action, there is a state of hypermetabolism. There is increased mitochondrial oxidative metabolism, increased ATP consumption, and because of increased ATP consumption, there is increased metabolism, increased production of heat or hyperthermia. So excessive heat production resulting in hyperthermia, the basal metabolic rate is increased, so hypermetabolic state, metabolic rate is increased. This results in weight loss in spite of increase in appetite. Also, there is risk of acute adrenal insufficiency. This occurs because of increased metabolism of cortisol, leading to increased cortisol clearance and relative adrenal insufficiency. Also, there is increased cortisol demand because of the stressful response. There is increased action of the thyroid hormones on the adrenal glands to produce cortisol to meet the metabolic demands, and therefore this can precipitate acute adrenal insufficiency. Secondly, there is increased catecholamine hypersensitivity, there is increased expression of beta-adrenergic receptors and sensitivity of these receptors to circulating catecholamines. And because of excessive sympathetic activity, because of excessive adrenergic activity, this results in cardiovascular symptoms such as palpitation, tachycardia, arrhythmias. Also, there is stimulation of the central nervous system causing delirium, seizures, and can also lead to coma. Neuromuscular symptoms such as tremor and hyperreflexia are common in hyperthyroidism. Thirdly, thyrotoxic crisis leads to hyperdynamic circulatory state, increasing the cardiac output. This happens because of increased metabolism of the tissues, that is increased metabolic demands of the tissues, and to maintain the tissue perfusion, the cardiac output increases. Also, there is excessive sympathetic stimulation, there is adrenergic activity, and this increases the cardiac output, and because the workload on the heart increases, the oxygen consumption increases, the workload on the heart increases, this increases the risk of high output heart failure. So pre-existing cardiac disease might decline, particularly heart failure and angina, which are conditions of increased oxygen demands where the oxygen consumption increases, leading to angina and heart failure. Lastly, excessive sympathetic stimulation can increase the gastrointestinal hyperactivity, increasing the motility of the intestine and causing diarrhea as a symptom. Thus, some of the key pathophysiologic changes include hypermetabolism, adrenergic overactivity, increased cardiac output, and lastly, gastrointestinal hyperactivity. A quick overview of the clinical presentation of thyroid storm: cardiometabolic manifestation, cardiac symptoms such as palpitation, tachycardia, arrhythmias, and a decline in pre-existing heart disease such as heart failure and angina. Metabolism increases and this causes weight loss despite increase in appetite, and also there are irregularities or erratic blood glucose control in pre-existing diabetes mellitus. Gastrointestinal symptoms such as diarrhea, nausea, vomiting, abdominal pain, bloating because of increased motility. Neuromuscular symptoms such as tremor and hyperreflexia. Also, stimulation of central nervous system leads to neurological symptoms such as delirium, seizures, Coma can also occur in thyrotoxic crisis. The thyroid gland appears enlarged. There is diffuse enlargement of the thyroid gland in Graves' disease or asymmetrical enlargement in case of nodular goiter. The thyroid gland appears enlarged. There can be diffuse enlargement in Graves' disease or nodular or asymmetrical enlargement in nodular goiter. In females, there can be a decline in reproductive function, decrease in fertility, oligomenorrhea or amenorrhea may occur. Gynecomastia in males is a possibility. Also, there can be decreased libido. With respect to skin changes, there is thinning of the skin, increased hair loss, sweating, and increased sensitivity to heat. So, increased sweating, increased sensitivity to heat, hair loss. So, these are some of the manifestations, the clinical presentation of thyrotoxic crisis. Thyrotoxic crisis is characterized by elevated T3 and T4 levels and excessive thyroid action. Therefore, the therapeutic goals are aimed towards decreasing the thyroid hormone synthesis, blocking the release of thyroid hormones, thus decreasing the thyroid hormone levels in the circulation and reducing the thyroid hormone action. And thirdly, decreasing the peripheral conversion of T4 to T3. As we know that T3 is the active form of thyroid hormone. Decreasing the conversion of T4 to T3 also helps to control the symptoms of hyperthyroidism. Treatment is also directed towards controlling the systemic manifestations of thyrotoxic crisis. Now let's discuss the steps in the management of thyrotoxic crisis. Thyrotoxic crisis is a life-threatening condition and requires ICU admission and monitoring. Cardiac monitoring for presence of tachycardia, arrhythmias. Vital signs have to be monitored, for example, heart rate, blood pressure, respiratory rate, temperature. Neurological assessment for delirium, seizures and coma. Airway, breathing, circulation is essential. So, oxygen supplementation to maintain the SpO2 levels greater than 94%. Mechanical ventilation may be needed if respiratory failure develops, and also IV fluids such as normal saline and 5% dextrose is given to prevent dehydration and hypoglycemia. The second step is to block adrenergic hyperactivity because there is excessive sympathetic stimulation. Inhibition of sympathetic stimulation or inhibition of sympathetic activity is done by giving beta blockers. Amongst the various beta blockers that are available, propranolol is preferred in the treatment of thyrotoxic crisis because in addition to blocking the beta adrenergic receptors, they also inhibit the peripheral conversion of T4 to T3, which is the active form of thyroid hormone. So it decreases the levels of T3, helps to control the symptoms of hyperthyroidism. Esmolol can be given by IV infusion, especially in critically ill patients. It has a short-lasting action and it is administered parenterally. If beta blockers are contraindicated, for example, in bronchial asthma, calcium channel blockers such as diltiazem is used. Step 3 in the management of thyrotoxic crisis is to reduce the excessive thyroid hormone action. And this is done by using drugs that inhibit thyroid hormone synthesis and drugs that block thyroid hormone release. So, propranolol is an anti-thyroid drug that inhibits thyroid peroxidase enzyme, decreasing the thyroid hormone synthesis. Also, it has a dual action. In addition, it also inhibits the peripheral conversion of T4 to T3, which is the active form of thyroid hormone. So, because of the dual action of propylthiouracil, it is preferred over methimazole in the management of thyrotoxic crisis. But once the patient is stabilized, propylthiouracil can be replaced by methimazole because of lower hepatotoxicity. Because methimazole has a better safety profile compared to propylthiouracil, it can be used as an alternative once the patient is stabilized. But in severe thyrotoxic crisis, propylthiouracil is preferred. There are anti-thyroid drugs that block the release of thyroid hormones such as iodine therapy, lugolcidine, sodium iodide, potassium iodide. So they are known to induce Wolff-Chaikoff effect. which prevents new synthesis of thyroid hormone by inhibiting thyroid peroxidase enzyme, decreasing the synthesis and release of thyroid hormone. Also, the iodine therapy has rapid onset of action, causes immediate blockade of release of thyroid hormone. So the action is immediate, and therefore it is given 1 hour after the administration of thioamides. So 1 hour after the administration of thioamides, after the administration of propylthyrosol, decreases the new synthesis of thyroid hormone and also blocks the release of thyroid hormone, thus controlling the symptoms of hyperthyroidism. The fourth step is empirical treatment with glucocorticoids, for example, hydrocortisone administered at a dose of 100 milligram administered intravenously and 8 hourly. So, hydrocortisone produces various actions. Firstly, it inhibits the peripheral conversion of T4 to T3, which is the active form of thyroid hormone, thus helps to lower the levels of thyroid hormones. Secondly, they also prevent and treat adrenocortical insufficiency. So, adrenocortical insufficiency is prevented, treated. Thirdly, it reduces inflammation that is associated with the autoimmune thyroid gland, particularly in Graves' disease, because of its anti-inflammatory property of glucocorticoids. Step 5 is to control fever and symptomatic measures. Use paracetamol and avoid non-steroidal anti-inflammatory drugs and aspirin. So non-steroidal anti-inflammatory drugs and aspirin is avoided in the management of thyrotoxic crisis because it displaces the thyroid hormones from the plasma protein, thus increasing the free thyroid hormone levels and increasing the symptoms. Therefore, paracetamol is preferred for reducing fever, for treating fever associated with thyrotoxic crisis. Additionally, cooling blankets, ice packs and hydration to be maintained to prevent reduced fever and reduce excessive hyperthermia, which is associated with thyrotoxicosis. Lastly, to prevent recurrence of thyrotoxicosis once the patient is stabilized. So, identifying the underlying triggers and treating the underlying cause is necessary. So, if infection is suspected, administer antibiotics. Consider definitive therapy once the patient is stabilized. Radioactive iodine therapy is used if the patient is not pregnant, and total thyroidectomy can also be used for the treatment of thyroid disease. To sum up the steps in the management of thyrotoxic crisis, ICU monitoring of the patient is essential because it is a life-threatening condition. Block adrenergic hyperactivity using drugs such as propranolol that decreases the sympathetic activity. Reduce excessive thyroid hormone action by giving drugs such as propylthyrosol and iodides that decrease the synthesis and release of thyroid hormone and helps to control hyperthyroidism. Administer glucocorticoids that prevent and treat adrenocortical insufficiency. They also help to reduce the systemic manifestations of thyrotoxic crisis. Cooling measures are followed to reduce hyperthermia and prevent excessive heat production. Identify and treat triggers for hyperthyroidism. For example, if infection is suspected, give antibiotics. Lastly, definitive therapy such as radioactive iodine and total thyroidectomy is done once the patient is stabilized to prevent recurrence of thyrotoxicosis. So with this, we come to the end of this topic. If you find my video useful, please like and subscribe to this channel. Thank you for watching.